Hi, everyone. Thank you for joining us. Like I said, my name is Levine Gongo, and I am with NCs. We're going to go ahead and get started here. So as people are trickling in, we're going to do a few housekeeping items real quick. Just a reminder to all, please mute your line, and we will have time for questions at the end of the webinar. So please hold your questions for the end. You can type your questions also into the chat box or at the end when you speak directly into the microphone or your phone. And you should have access to your own mics, or if you do, then we'll be able to hear your questions. If you have any tabs that you aren't using, tabs on your computer, please go ahead and close those to save bandwidth. And just a reminder that this webinar is being recorded, and we will upload a recording of our website on our website, which I will send a link to after the webinar. So I'll go ahead and introduce the speaker today, Dr. Amy Caruso-Brown. Dr. Caruso-Brown is a pediatric hematologist, oncologist, bioethicist, and medical educator at SUNY Upstate Medical University, where she directs the Ethics and Professionalism thread in undergraduate medical education. She also designed and directs the Patient to Populations program, a justice-centered bioethics course for first-year medical students, the curriculum for which was recently published as a textbook. Her research interests include evaluation and assessment in social determinants of health education, pediatric disagreements, and ethical issues related to social media. With that, I will take it off to Dr. Caruso-Brown.
Hi, everyone. Thank you. I'm so glad to be here and to be talking about this, and I hope this will be a really interesting discussion. I think we did the announcement. So I have no conflicts of interest to declare. And today, so I'm going to go do a little bit of an overview of what we know about the impact of bias in medical education, e.g., why do we care, and how do we sell other people on this being important, some of the challenges that we've encountered in identifying and addressing bias, and then really where this checklist idea came from, how we developed it and implemented it and are still actively implementing it in our institution, and some next steps, things that we're already anticipating changing about the checklist, places where I would love to have collaborators from other institutions, and questions that I have from which I would love to have feedback and how we can do this better and make it more impactful. So this is how it starts. This was a couple of years ago, and I got a call from an administrator at my institution, and he said, hey, Amy, I was just wondering if you could develop like a one-page handout for our faculty that would just fix this whole problem, teach them about bias and microaggressions. And this came a little bit out of the blue. I was, as mentioned in the introduction, teaching a course in which these themes are very prominent, in teaching about social determinants of health. I found out really quickly that I got labeled as the expert in this area long before I was actually an expert. So that was where the question came from, and I paused, and I was really tempted to give a very short response, but I started thinking about, well, what could we do instead? If a handout is not going to fix this, which I was pretty sure it wasn't, what other options might there be? But before I answer my own question, I want to take a step back. I have a slide on definitions. I'm not going to go through all of them, but because many people use these terms to mean different things, and because I'll be talking about some of them, I wanted to give this to you all as a reference for how I'm using these terms. But in general, these are many, many problems that we've grouped under one heading. So when we're talking about bias in medical education, we're talking about presenting scientifically inaccurate content, like racial essentializing. We're talking about presenting content that overemphasize certain topics while neglecting others. We're talking about sometimes presenting content in a way that is very stigmatizing or shaming, and I'll give examples of all of these as we go through this, or ways that promote bias towards people in a certain group or with a certain medical condition. And sometimes we're even talking about presentation of content in lecture or on the wards that is totally unrelated or irrelevant to medicine, but still promotes bias or discrimination, like joking and other comments that can be received as microaggressions. Some of the examples, so promoting race as a biological construct, I'll talk more about that in a bit and show some really good studies that show the impact of that on students. really disproportionate representation of white skin in particular. That has come up in a lot of studies and in our own institution, that dermatology lecturers tend to disproportionately or sometimes exclusively use photographs of white skin. Positive images tend to show white able-bodied people, while more negatively framed images are more likely to show people of color or people with disabilities. We find that certain topics are underrepresented: disability, geriatrics, reproductive health, especially contraception and abortion, are frequent examples of that. LGBTQ health topics are often underrepresented. Fat shaming is really pervasive, and a lot of people and scholars have labeled this sort of the last widely acceptable form of discrimination, and it's certainly pervasive in medical education. There's a lot of examples of very stigmatizing language. Just the phrase that people use all the time in medicine and medical education, that the patient admits to something, automatically stigmatizes that disclosure. And then stereotypes tend to be promoted. Poverty gets equated with laziness. Many of my students, when we were developing cases for my course and we presented a family dealing with end-of-life issues they were originally from Mexico and they were Catholic, and a student came back to me and said, wow, this is the first time I've ever seen a Latino family presented who just seems like mine, who just seems like an average family, who's not undocumented, doesn't have huge other socioeconomic challenges, but just an average family. And the students receive that really positively, but I think often that's not the way we do it. We bring in diverse patients into our vignettes when we want to make a point about culture and ethnicity, and not just in recognition of the fact that all of our patients are diverse and come from diverse backgrounds. So those are some of the issues we've encountered. This study hopefully is widely known to a lot of people. This is a student-led analysis of lecture slides, preclinical lecture slides, so from the first 2 years of medical education, done at Brown University a few years ago. And it highlights a really pervasive problem in the preclinical lectures, which is the way in which race is just thrown out in lecture without a lot of discussion or explanation or context. So race-based associations are given, sometimes implying biological differences where there may be none without any further context or explanation. Sometimes social and structural causes are mentioned, but even then, they're often not with enough detail or context for students to really understand and apply that information. Epidemiologic associations get just put up on slides, pulled from studies, and students leave these lectures without a lot of understanding of how race really does matter in medicine. They get these numbers that really don't mean very much. So I think this is a great example of the problem of bias, particularly in the first and second year lectures. There have been similarly styled studies done on test questions, and similar to what I was mentioning earlier, this study was of USMLE Step 1 test bank questions, and they found about 20% mentioned race. Of those that mentioned race, 85% were white non-Hispanic patients, but they saw this really interesting division here. When race was irrelevant to the question, it was just sort of thrown in there, but it didn't actually have any bearing on the answer or on what the question was really about. The patient was much more likely to be white. When the reference did matter, when it was, say, a question about sickle cell disease that was meant to be leading in that direction of race-based associations, it was much more likely to be a patient of color. So I think this goes back to the ways we use race as a proxy for genetics, for social class, for culture, and not for this really important discussion of social experiences of groups that are relevant to health. I think I covered up part of my slide. Okay, so this is the study that I use most often with faculty, especially preclinical faculty, but all faculty who are struggling to understand why this matters to what they do and to what they're teaching. So this was a study done at the University of Virginia. They recruited both medical students and lay participants. And they had them do a couple of different things. They had to rate the amount of pain they would feel across scenarios. They had to rate the extent to which they thought that 15 different biological differences between blacks and whites were true. Some of them were true, many of them were not. And then the people coming from medical background, the students and residents, read through 2 clinical vignettes and made pain ratings and medication recommendations. And they also completed the measure of biological differences that the lay participants completed. So what they found Lots of people held false biological beliefs. So lots of the participants rated as true things that are not in fact true, like whites have a better sense of hearing compared with blacks, or black skin is thicker than whites. So really, in some ways, things that shocked me a little bit, but lots of people said they were true. An interesting and alarming thing is that the percentage of incorrect answers actually increased between the first and second year of medical school among the medical students. So during medical training, people began to hold more false biological beliefs than they started medical school with. And I don't think that's because we're teaching them false things. I think that's because we're teaching them that race is biological. We're teaching them that one false fact, and they generalize it to other things. What they also found as a consequence of this is that the more false biological beliefs the participant held, the more likely they were to treat the pain of hypothetical Black and white patients differently. So this is where we take the step from presenting biased information in medical school to graduating people who hold more false beliefs and actually adhere to these biases, to graduating people who go out and practice and treat patients of different races or who are different in other ways differently. And I think this is really the heart of why we care about bias in medical education. There's many systematic reviews looking at implicit bias in healthcare and looking at the impact on practice, and I would just say it's really well demonstrated across these studies. I encounter a lot of people who pull out the problems with the implicit association test and use it as an argument against the existence of implicit bias. And what I try to convey here is that is not true. You can critique the IAT, lots of interesting methodological things to say about it, but the studies of implicit bias by many different measures, both in practice and in the laboratory and in social psych labs, are really good and really strong, and they certainly show that patients are being treated differently in practice. Oh, I want to mention microaggressions briefly. There is a really interesting University of Florida study of medical students that came out recently. A little bit more than half of the students were familiar with the term, and a little bit more than half said that they had experienced microaggressions in medical school. Women were more likely to report this than men. They actually didn't break down their sample by students of color versus white students, so I couldn't report that comparison, but they did see that women were more likely to report this. And when they asked them for examples, they brought up things like being called demeaning nicknames, particularly as women, being called darling or honey, or being told that they shouldn't go into a certain field because it wasn't compatible with family life. That was really common. They also had some interesting comments about the content, particularly in the preclinical years. So I wanted to read this one example from a student who said, "Our school solely presents gay men in question stems in order to present a question regarding HIV/AIDS. I think that goes back to what other studies have shown about test questions. This has made me feel unsafe. We've never been presented with a gay woman, which has made me feel invisible." So these are the kinds of things that students appreciate in our lectures that we may miss. And as I'll talk about the challenges we face with the checklist, one of the real challenges is that the students are in these classes every single day where no lecturer is. So we see a little snapshot of the curriculum. The students see these things happening pervasively over and over and over again. And what may seem okay in isolation or an understandable oversight in one lecture becomes a real problem when it's all of the curriculum over 4 years. So why is this hard? Why is it not a math? Why couldn't I just make a one-page handout and fix this problem for our faculty? I think some of the issues are that many of our faculty, those who are devising curricular content in the UME space, are not familiar with these concepts. Knowing about the social determinants of health, if your focus is biochemistry, probably not your priority, or it may be your priority in your personal interests, but it's not as relevant professionally as it is for someone like me. And so I think it's unsurprising that some of our faculty members are unfamiliar with these concepts. Even where there is an intersection between their areas and things like SE. I think I have a little bit of feedback, so if anybody else is hearing it, just let me know. So they may not realize how to interact. And then I think a lot of faculty are inexperienced with discussing bias in the classroom and uncomfortable discussing bias in the classroom. And I can recognize and relate to that. It is a big leap to make the first time I talked about racism with my students openly and asked them to engage in that dialogue. And I think for me, I'm very motivated to learn about these things and to address this because it's so close to what I'm teaching. Again, for many of our faculty, it's not. It doesn't seem like the priority when they're talking about molecular interactions and proteins. So it becomes much harder to put themselves out there and to start learning about these things and learning how they should be teaching about them. The other issue we face is that the concerns often come up retroactively, which really puts the burden on the students to identify and report any problematic content. And sometimes the reporting mechanisms, particularly if students are afraid of retaliation, the reporting mechanisms are anonymous, and it can become really hard to pin down, well, what exactly happened in which class, and did it happen in several classes, and how are we going to fix this? It's also hard because we're bad at this everywhere. There isn't really an easy fix for mitigating bias anywhere in the world, not just in the healthcare and medical education space. Part of the problem is positionality. It's that people's position and circumstances, that leads to what we perceive or don't perceive. So it can become really hard for us to imagine how this looks from the position of someone who's not us. There's the piece of discomfort. We are, as a culture, often uncomfortable talking openly about things like race and sex. And many people associate talking about these things or disclosing their biases with labeling themselves racist or sexist. And they much prefer to not acknowledge it in that way because that makes people feel like they're bad in a way. And I think there's a lot of, there are certainly people trying to advocate against that and to acknowledge that we all have these biases, but there's still a huge percentage of our faculty who don't agree or who still feel that they are being labeled or stigmatized themselves if we're talking about bias in their lectures. Effective strategies require a lot of effort. And the last piece is that we don't have a lot of real-world data, so most of the interventions on mitigating bias are only tested in a lab, so we haven't actually seen how they play out in the classroom. Does anything work? So the best evidence that I have found looks at bias and prejudices as a habit and tries to develop a habit-breaking intervention, but that requires the initial motivation to break the habit. And what I was trying to address in answering this question was, what do I do about people who don't start out with that motivation? How can I lower the bar so that we reach all of our faculty and not just those who are motivated enough to go to a class, to go to a workshop, to learn more about this? So the answer that we came up with was this idea of a checklist. And this is just a screenshot of what the paper version of the checklist looks like. This is pretty much how it started in the first version, although the questions have changed. And my thought was, we've used checklists successfully in healthcare in many, many different areas of healthcare to improve quality, to improve patient safety. And the idea is not that people will never make mistakes. The idea is that the checklist will catch the mistake, catch the error before it reaches the patient or causes harm to the patient. So that's the model that I was working from when I was thinking about applying a checklist to this space. I was thinking about bias and microaggressions as a problem of safety, the safety of both our current students, but also their future patients if we're educating them in a biased way and they go out into the community and that bias reaches patients and affects the healthcare their future patients receive. And my goal was to catch the bias before it harms the student or the patient, but really before it even harms the student. I wanted this to be a tool that any faculty member could use for any type of content, at least any type of formal content. I'll talk later. It doesn't work quite as well for the informal curriculum, but anyone who is developing or reviewing a piece of content, whether that's a test or an assignment, a lecture, a small group case for discussion, standardized patient encounter, that it could be applied to anything. And I wanted it to be self-explanatory. That you could sit down and use it and not have to do any kind of long training session before you picked it up and went through the checklist. I wanted it to be suitable for self-assessment, so I wanted it to be something where faculty could use it on themselves. And I wanted it to be non-punitive, and those things really go together. I didn't want faculty to feel like we were trying to catch them in the act of committing a bias in their lectures, for instance. I wanted them to feel like it was really a tool for improving their own work and helping provide better education to our students. We've been pretty clear from the beginning that this doesn't require and it doesn't replace other approaches to faculty development. So although we designed it to not need faculty development before using it, it also doesn't replace that. There is still absolutely a role for faculty development and continuing education in this space. But we hoped that it would prevent that harm even if it failed to educate, that there might be an education component and some faculty may use it in conjunction with additional education, but even if they don't, if this checklist is succeeding, it'll still catch the bias and prevent the content from getting to students. And we also wanted it to really avoid burdening students, especially students of color, with the responsibility for calling attention to biases. Much before we developed this checklist, we had tried a system like that, where right now we have in our evaluation system a checkbox for mistreatment, where students can flag mistreatment having occurred. And we considered having something where they could flag bias as having occurred. And a lot of the students were really troubled by that. They were troubled by the implications about whether it would ever come back to them. So in designing this, I was thinking about that and thinking, how can we avoid that as a barrier to improving our education? The checklist is divided right now into 7 or 8 domains. We've moved it around a little bit. So there's race or ethnicity, which are separate blocks of questions, sex, gender, or sexual orientation, age, disability, mental illness, substance use, weight, immigration status, and poverty. And those have changed and been moved around a little bit while trying to both reflect that these are different. Some of the categories we've put together are definitely distinct, but also not wanting the checklist to have so many questions that people would not use it. And then we identified 2 content domains that were really unique and needed to be asked about explicitly, separate from the other questions. And those were visual images, which are a really, really problematic area in many ways. And as I recently tried to find representative images of students and doctors seeing patients to put into this clinical case discussion, and it was really hard. So I was really disappointed in Google Images for this purpose, but that's definitely an area where we've gotten a lot of complaints from students and concerns. And the other area is clinical vignettes. We are thinking now in future iterations about whether we need a section looking at things like the syllabus or reading lists and looking at bias in those aspects of a course or of content. So the next issue we ran into was how do we define these ideas of stereotype, bias, shame, or stigma? So the way the checklist is broken down, there are a lot of specific questions for race and ethnicity, somewhat fewer questions for sex and gender, but those are areas in which we know that patients tend, that the presentation of content tends to skew specific ways. For most of the other categories, the emphasis is just on asking faculty, do you think, looking critically at what your lecture, could anything in here about this category or this domain promote stereotypes, bias, shame, or stigma? So then the question came back, how are we going to get people to know what that is or recognize what that is if they're unfamiliar? So right now we give them this table with examples. And it's, of course, not perfect and not all-encompassing, but we hope that by giving faculty a few examples of what we mean by these things, that it'll help them to recognize potential examples in their own lectures. And these all came from students and from faculty identifying things that had happened in real lectures and in case discussions. So some of the ones that this first one, I think we had at least 10 students bring it up. In a lecture on obesity, the lecturer showed 2 photos side by side. One depicted a family of thin, white, athletic-looking individuals sitting down to a home-cooked meal, and the other depicted a family of overweight Black individuals sitting down to McDonald's. So very, very stereotypical on many, many levels, and very offensive to a lot of students, and really detracted from having a more important conversation about nutrition and how do we counsel our future patients about nutrition, which year after year is also something our students say they want more of and not in this fashion. So that was an example that I think a lot of faculty, when they hear that, they understand it much better than maybe they did before. Critiques about ethnicity have included presenting all Latino and Latina patients as undocumented immigrants and migrant workers, For gender, a very common one is in writing pediatric vignettes. The patients are often accompanied by a mother, rarely a father, and never more diverse forms of families, although in practice my families are enormously diverse and my own family is diverse in that way. And they often involve only nuclear families. In sexual orientation lectures, students are often taught to label sexual identities and behaviors as high risk. So we've really tried to educate faculty about discussions around risk. The checklist is not the easiest tool for that, but it does try to get them to think about that label. Are you labeling things as risky, and why, and who's getting that label? So sadly, because this is how low the bar can sometimes be, the problem of humor. Some faculty, again, totally understandably, use humor to better relate to students, to engage them, to put them more at ease. And we do know, and studies have shown this, that students are more sensitive to gallows humor than faculty are. But the checklist just contains a really simple message at the end of that table, and it just says, if your joke is about one of these domains, it's not acceptable. And the goal was to really eliminate where this had started was with a joke in an obesity lecture about teenage girls putting on weight in all the right places. And many students, again, understandably found that to be really offensive. So what we've tried to convey is just don't. This is not the place to try a joke. Particularly if you saw a late night comedian do it, I strongly recommend you do not try to reenact that with our medical students. It's just not the place for humor, and it often ends up being a microaggression or an aggression. So we put that on the checklist as well. Piloting the checklist has happened in 3 going on 4 phases. So in the first run, we had students and core faculty, so students who had identified interests in these areas and faculty who shared those interests, looking at it for content, for readability, for face validity. And that was the first run. We then identified a couple of organ-based units where the course directors were willing to try piloting it in their unit. And I would say these were not course directors who had any particular interest in this subject. They were just willing to work with us and to give it a try. And in that, we were really looking at feasibility and a little bit at inter-rater reliability, at whether we could get students to line up with lecturers, to line up with course directors. The goal being there, if the students identify a ton of problems that the lecturers can't self-identify, then we failed. Now we're on looking at multiple choice items on unit exams. This is ongoing, and the goal of this pilot was to look at validity and reliability. It's been longer than we expected because most of our unit exam questions already had race stripped out of them. So there was just no discussion of race for us to look at bias. So that's taking a little bit longer than expected. In terms of feasibility, so most of our users have found the checklist easy to use without assistance. There are generally not questions about what we mean about specific things. That doesn't mean they're picking up everything that we would pick up or hope they pick up, but they seem to understand it and be able to use it. One user did mistakenly apply it to his entire unit rather than to individual lecturers. So I'm mentioning this to tell people now, make sure you're really clear with your faculty if you're asking them to use this about what you're asking them to evaluate. It seems like a simple question, but the simple questions are the ones we should always make clearest. We looked at inter-rater reliability, and the only area where we really had trouble was gender. So this was interesting, and what seemed to be the case was that students and faculty couldn't decide on whether or not gender was relevant to a lot of things. So in the question about is the gender being mentioned for a reason, is it actually important to this topic or this situation, students and faculty didn't necessarily agree, and one of the issues there may be that students can't always see relevance, that faculty have greater expertise and can see. But I would say the lesson there for faculty is to make it more transparent to the students. So one of the examples given was this comment made by a lecturer that men can pee into the jug, but women can't. And the student in particular described it as an offhand comment about collecting 24-hour urine samples at home that was not offensive or stigmatizing, but a racist, non-binary, or trans people. So I think this is an area where we see greater sensitivity and awareness and knowledge really amongst our students than we do amongst our faculty, and it's a good opportunity for more education, showing that the checklist is really not the end point, but sometimes can also be a point for figuring out what do we need to do in our next faculty development. Cartoons and paintings were the images least likely to be agreed upon, and I think there was just a lot of trouble interpreting what was meant by including these images in lectures. But overall, inter-rater reliability was really good. So what did we do about detecting bias, and how has it been received? So right now, what we have faculty doing, if they use the electronic checklist, it prompts them with questions about whether they made changes, and so lets us track how often people are changing things in response. It also prompts them to reach out to us if they have any questions about it. So one example of a response that came back to us out of this pilot study was a course director who was also a lecturer realizing that the lecture included photographs of mannequins, all of which had light skin and typically Caucasian physical features. And as she looked into this, she discovered that we didn't have any darker skinned mannequins to use for these photos. So she reached out to the checklist team, and our recommendation was that she acknowledge it. There wasn't really an easy, quick solution for how she could fix where we've placed our school resources, although it, again, is a way in which the checklist helps identify things that we should address at a higher level. But we recommended that she acknowledge this, and she did. And the really interesting follow-up was that many students independently approached administrators and faculty members to share this story and to express their gratitude, that this really simple, I'm sorry that we have sort of only bought white mannequins, that we have been biased in this way, really resonated with students. And although it didn't totally fix the problem, they appreciated the effort. And I was really surprised how many different ways the story came back to me, showing it was actually many different students. In the pilot, the checklist users also frequently noted that when medical history was presented, the discussion often, unsurprisingly, consisted solely of white men's accomplishments. But they did bring up that a lecturer on cervical cancer, after using the checklist, he recommended that they read the book The Immortal Life of Henrietta Lacks, which he had recently read. And then he went on to talk about some of the knowledge regarding the natural history of cervical cancer, and that came from a study in New Zealand, this was unknown to me, in which women were intentionally left untreated. And again, a lot of students circled back to say that they really appreciated the additional background and commentary. They appreciated knowing that their lecturer was interested in learning more and understanding the disparities in this field and in their specialty. And again, it doesn't fix everything, but I think it highlights how well received small changes can be by students, and how much they appreciate just knowing that we're trying to address these issues. What are the challenges that we have run into? So logistics is the one we're currently confronting, because we are looking at rolling this out as a required thing done across all lectures as part of our continuous quality inventory, so that we can continually look at this over time. And so the questions become, who's going to be responsible for implementation for tracking? There is that question, is it going to be required or optional? What are we going to do if people refuse to fill it out? Other things that are measures that we need to look at institutionally are not optional. Is this different? So we're asking those questions right now. The resources required for responses, right now it's been pretty manageable, but depending on the size of your institution, how wide a rollout of a project like this and how many questions you get back, it may be more than 1 or 2 people could handle in terms of helping faculty figure out their responses and figure out how to change their content. Awareness of content across sessions is something that the checklist doesn't do a great job of, particularly for lecturers who don't do a lot of teaching with the medical students, or with any group of students, because they tend to not have a good big picture of the curriculum. So in any one lecture, one vignette, it may not be biased to present. We actually should talk about the needs of our undocumented patients, for instance. So some of those concerns, like all the Latino patients in our vignettes are migrant farm workers, that's okay for one vignette, but when it becomes multiple vignettes or multiple lectures over the course of the year, that's where it becomes a problem. And the checklist doesn't really help the individual lecturer figure out what's happening across the whole curriculum. So one of the questions we're still asking is, how do we look at both the forest and the trees? How do we use the checklist to assess individual lectures and to look at our curriculum from a bigger point of view? Understanding of gender is probably the biggest thing that came out of the pilot in terms of being the area of the most disagreement and discrepancies. We still encounter some resistance from faculty, perceptions that there's judgment embedded in this, that just the existence of a tool like this is trying to catch faculty out somehow. And I have tried to really push back against that by explaining the development and the rationale and the intent. And occasionally we get some resistance from students who hear about it. And they hear about it when lecturers make changes. And so we've had at least one student come back and complain about perceptions of political correctness. And they actually complained that their peers were whiny. So I don't know, that has not been pervasive, but it may be something that we have to confront more in the future as we roll this out on a larger scale. So some of the comments from faculty, are we turning the students into the faculty police? I think that we are not, but we do have to recognize that the students are the only people really who truly know the entire curriculum inside and out. But last year, everyone laughed about jokes. I have heard that a lot, and I just keep trying to say they did, but a lot of people were probably uncomfortable. Just because a lot of people in the room are laughing doesn't mean that there aren't a lot of people who aren't comfortable with the joke. And this perception, I only talk about enzymes. I put all of these in quotes. So that's the person saying, I don't need to fill this out. This doesn't apply to my lecture. So trying to get people past that point to say, no, this applies to everyone. If you are teaching students, then there's potentially bias in your lecture, and this is worth using. If you breeze through it because you don't talk about humans at all and never mention any of these things, fine, but sit down, give it a chance, see how it might apply. Students, I mentioned my peers are whiny. I can't believe my teachers are wasting their time on this. As I said, these are uncommon at this point, and I think it just remains to be seen what happens as we roll this out on a larger scale. Limitations. So this doesn't require that faculty learn from the checklist. So it doesn't directly mitigate bias amongst faculty. It doesn't necessarily identify gaps in content. We ask a little bit about under-overrepresentation, but some of these things, like the fact that we were spending more time in our curriculum a few years ago on drugs for erectile dysfunction than contraception, it wouldn't necessarily catch a gap like that. And it can be difficult to apply to clinical and bedside teaching. So we're still figuring out how it does, if at all, or whether there's some other tool that we can use to address the issues that come up at the bedside. So this is what are faculty learning from this? We don't really know yet, although I certainly hope to find out more. So we hope this promotes some self-reflection. It certainly does for me as I use it. We think that the faculty who reach out to us acquire new knowledge through their conversations with us or through their own research. And we think that we hope that the positive reinforcement from students is good, that faculty feel that their efforts in this area are valued. Our next step is the required use in all preclinical courses, coupled with surveys of a subset of faculty to see what they really are learning. And we're thinking about modifying it to promote more intentional perspective taking as you go through the checklist and some of these other strategies for bias mitigation. Is there a role for additional training? So probably yes. So one of the things that we may do next is develop some online modules for faculty who've completed the checklist and think, okay, I want to understand more about this. I checked yes to a few things. I think I might need to change something, but I'm not sure, and I'd like to learn a little more. So that's something we'd like to offer to some faculty. It would still be voluntary. How do we identify our gaps in content? So this is the tough question. It'll always be difficult for anyone, for me, for anyone else, to identify something that's missing if we don't know what that something is. But we do think there's some ways, we've gotten some feedback that there's some ways to tweak the checklist to better elicit identification of gaps. So we will keep refining the questions, and that goes for the checklist that's available online as well. That as we get feedback, we try to refine those to make them clearer, to make them more useful. And we're also trying to identify content areas from looking at all the checklist data that we collect. What are the areas that are particularly prone to this problem so that we can proactively tell faculty about that as we have an organ-based curriculum. In the future, we might be able to give faculty as they take over a unit or take over a particular set of lectures information about where the most problematic places have been in the past. What do we do about the informal curriculum? So I firmly believe that the best preclinical curriculum in the world doesn't carry more weight with students than how they see medicine practiced and healthcare provided in the real world. So our next steps actually are moving away from the checklist a little bit for this question. So we have a study open looking at best practices for bedside teaching, and what we're doing is interviewing faculty who have been nominated by students or peers for being really good at this type of teaching, for being good at making these issues, social determinants of health, discussions of racism in healthcare, discussions of poverty, really transparent at the bedside, and helping students see how they address these with their patients. And then we hope to develop some faculty interventions to improve teaching in those areas. And then eventually, I think where this needs to go is better measures of assessment to motivate and engage students. Finally, I wanted to mention a couple other resources in the general vein of this checklist idea or assessment tool idea that are out there. So there's a gender bias calculator that screens narrative feedback, letters of recommendation, things like that for gendered language, developed by Tom Forth, and it's available online. And there's also an assessment tool developed by Jane Sumner, who I think is a law professor, that looks at gender balance on syllabi. And I know a lot of medical courses don't have lengthy syllabi, but we do have some. Mine has one of the longer ones. And for this, you can upload your syllabus, and it will give back a gender balance of authors, which is thought to be one of the issues in the citation gap, that students are more likely to be assigned male authors than others. So these are two other tools that if you're thinking about using the checklist or interested in this generally, you may find this to be useful. I think that is it. I am open to questions, comments, ideas, suggestions. I would love to hear your feedback.
Thank you so much, Amy. We have a few questions, and if anyone else has any additional questions, please put them in the chat box, and we will read them out loud so that they're all recorded for people to listen back at the webinar. Our first question is, I may have missed it, but could you speak on the validity of asking a microaggression questions without categorizing responses by race?
On asking, from the Florida study?
Yes.
Yeah, so they did. They did categorize, they had race data, but they didn't present a breakdown of the frequency of reported microaggressions between their students of color and students of non-color, or white students, sorry. That made no sense. So I thought that was I assume they had that data because they collected it, but they just don't report it in the paper. So that was a little bit disappointing because I was curious. I mean, I think we could all theorize about what we would find. But they didn't actually publish that part. They published women versus men, and then they looked at some subgroups within that, but not the overall students of color versus white students. So yeah, so I think that's an oversight. I don't know why it wasn't in the paper.
Thank you. Our next question. There was a scenario here where residents in a primarily white program located in a predominantly Latino Latino community were asked to reflect on this racial lingual dynamic that might present as a problem. This survey/focus group session was met with resistance, with the primary response from the residents being, "Aren't we enough?" How would you address/respond to this?
Oh, that sounds like the start of a really interesting discussion. So aren't we enough in the sense that they felt like just the fact that they were there should be enough and they shouldn't have to reflect on cultural differences or linguistic differences? Am I understanding that correctly?
Yeah, in part, I think it was that. I think also just, having this conversation they didn't find was relevant if it didn't really address how they directly cared for their patients. It was just more so talking about, the racial and lingual dynamics and, what issues might come up, given that you are a predominantly white program serving a predominantly Latino community. I think, they took it to offense a little bit. There was some pushback, but mostly like, aren't we enough? Like, aren't we doing our jobs right? Aren't we treating people the way they should be treated? Things like that.
It reminds me of a conversation I had with our male medical students about being on OB, and I've tried to I'm trying to take the perspectives of all people in these situations now, more maybe than I used to, and at least appreciate, though I think the students our residents are wrong to fully dismiss the assignment, but I'm trying to appreciate that they do feel a little bit hurt, that there actually is a little emotional hurt component on the part of students and residents feeling that they aren't enough. But coming back to, no, it's not enough for anyone in medicine to not be thinking about the perspective of the patient and how it looks to the patient to have a provider who doesn't share any of their background. And I think there's lots of great and maybe what would I do with, I'm trying to think what I would do with those residents. There's got to be a senior resident in that situation, or someone who is willing to speak to the time in which it really mattered, because everyone's had the encounter where a difference of culture or language or race or ethnicity affected the patient's care. An assumption that I make as a white heterosexual woman doesn't help my patient get the care they need. I think we've all had those experiences. So sometimes what has helped with my students is getting the more senior person, whether that's a more upper level resident or a sometimes fourth year medical students, because I teach a lot in the UME space. Fourth year medical students are really helpful because they can say, no, this really happens and this really is a problem and this really affects our patient care. And then it feels a little bit less like the faculty member telling them exactly what to do and telling them that they're not enough. But I do appreciate that feeling of most students and most residents truly come from a place of wanting to help people, of wanting to help make people better. Realizing that you're not enough if you don't think about these things is a hard realization. It's one we all need to have, but it is challenging.
That was great insight. Thank you, Amy. The next question is asking to go back to the links for the tools.
Uh-huh.
And we will also, we will be, posting this on our website, so you'll be able to see the links as well. Patrick, I see you asked that question. Did you have any questions about the links specifically? I'm not sure if he's typing.
I've tried the syllabus one. I have not tried using the gender bias calculator. Interestingly, it came to me from a physicist and computer scientist who I know socially. So it's being used outside the medical field in many other fields, and I think it's potentially a really interesting tool. It's certainly a problem that we see with third year assessment with the narrative information we get back about students, that certain expectations are encoded for female students and students of color that are not necessarily there for white male students, and it shows up in their narrative, unfortunately. So I'm interested to see if this is something we can adopt a little bit more widely or adapt for something besides gender, but it seems like a cool resource that may be helpful to some of you.
Thank you. The next question is, you may get to this, but how did you train faculty on the checklist/bias?
So we didn't. That was the goal of the checklist, was to not have to train them. So the information that is at the top about sort of here's what this is why we're doing it, you should take your piece of content and go through it with the checklist, is the extent of the training that we gave them. And that's why when we did the first pilot, we also had students doing it, because we wanted to see, are faculty going to pick up as much about themselves as students pick up about them? And it does generally seem to be true. It's not perfect, but the reliability between those two different observers seems to be pretty good, with the exception of the gender issues. So the goal is to not have to do for this. It's, and as I said in the beginning, it's not replacing other forms of faculty development that we might do, but the goal really was to have any faculty member be able to do this and pick something up and then come back to us with questions. So we're not expecting that every faculty member who goes through and says, oh wait, look, all of my pictures are of white people, or more commonly, all of that they're presenting a lot of race-based associations. That is still a really big one, and that they don't know what else to say or what else to do. The race-based correction for, this is not my area of expertise, but the idea of a race-based GFR or a correction for African-American GFR, the students bring that up a lot, and the faculty teaching that material don't necessarily know how to change it or address it or improve it. So we definitely made it clear to faculty that we're not expecting them to be able to make the changes based on the checklist, but we hope that with the checklist, they can identify those areas and then come back to us. We help coordinate connecting them with other experts or answering the questions ourselves if we can, but connecting them with people who have the expertise to help them improve their content.
Thank you. The next question is, what happens when students, in quotes, discover bias that faculty don't? How do you approach faculty with that information?
It depends. It's a very context-specific question. For some faculty, like in my course, it's easy because I can go to my lecturers and say, we noticed this and this is concerning, and let's talk about some ways that we might change it. And I can sort of own that. For faculty in other courses, some of it's dependent a little bit on whether students were comfortable with us openly addressing it. So sometimes the concerns have come back to me in a, I want to talk to you about this kind of way, but I don't want you to go to the faculty member and talk to him or her about it. And that's been really, really challenging. And I'm trying in the ways that I talk to students and invite students to contact me to put up front that I'll always respect their desire to stay anonymous or to not have things addressed. But it's really hard to improve. If I hear about these things and then I'm asked not to do anything about them, it's really hard for me. It's hard for me to improve things. But I've tried in presenting the idea of the checklist to my faculty and in doing other faculty development to present it as this is not about somebody doing something bad. This should be treated no differently than you presented a factual error, which some of these are factual error. A lot of the race essentialization is a factual problem, is a failure of science that we need to improve the way we're teaching that science. And I think we should treat it just like any other feedback that we might get. The students, hey, when you presented that aspect of cardiac physiology, the students really didn't get it. So I've tried to frame it that way for faculty. And I think most faculty are receptive. One of the potential backfires is where faculty say, oh, I'll just cut it, like where they just slash part of the content rather than have to figure out how to talk about a sensitive issue in a nuanced way. And that's a disappointment. And I have control over the lectures in my course, but I don't necessarily have control over, I don't have control over any other lectures in the curriculum. So if that's what faculty decide to do, I can't really stop them.
Great, thank you. Is there any other questions? While we're waiting, I'm going to enter the link for the evaluation in the chat box. Please complete. We appreciate any feedback and moving any changes we can make to future webinars or any topics that you may be interested in for a future webinar. We really use this feedback, so please, you can take the time to complete it. That would be very helpful. But if you have any other questions, we do have a few more minutes. Are there any improvements you give to faculty available for others to see?
Sorry?
Sorry, are there improvements you give to faculty available for others to see?
Oh, that's no one's ever asked me. Yes, I mean, they totally could be. I have no problem sharing them. They're very diverse in what the question was and what the issue was. So if anyone has a specific area that they're interested in, then just reach out to me and I can see if we have any that we have addressed in that way. The other thing that we'll probably be able to say more about in the next year will be rolling this out on a required across the board scale. Then we'll be able, right now it's just me sort of addressing things as I hear about things, but then we'll be able to track what changes were made on a wider scale.
Great. The person asking the question says wonderful, thank you. Any additional questions? We'll hang out for another 2 minutes if anyone else has additional questions before we end the webinar. Now, I added the link again to the evaluation, so it's at the end so everyone can exit.
Thank you so much.
Thank you, Amy, and thank you everyone that joined us today too. The webinar will be available on our website by the end of the week. We'll post it on our Twitter page and include it in our upcoming newsletter so you can share with anyone else that you think would be interested in viewing it. Okay, thank you everyone. It's 12:30, so we're going to end the webinar. Thank you again, Amy. We really appreciate it.
You're welcome. Thank you.
Thank you.